Welcome to the show. On today's episode, we have Peter Koshland. He is the CEO and head pharmacist of Koshland Farm. In his 20-year career as a pharmacist, Peter has seen the profound impact high-quality compounded medicine can have on the lives of patients. He works with doctors and patients on individualized integrative therapies. In this episode, we will discuss compounding for hormone replacement, dermatology, thyroid disorders, and pain management. Hello, how are you today?
Doing great. Great to be here with you.
I have so many things to ask you about compounding. So first, tell us a little bit about yourself and how you got into compounding.
So I am a pharmacist, traditionally trained, and went into kind of the retail setting. And I think like a lot of people who go into healthcare, I really wanted to be in a kind of a service type career where I would felt like I was really helping people get well. And I wasn't until I was into my career that I discovered compounding, and it fit kind of some of my goals for my career, which was that I could be creative, which isn't really something you think of with pharmacists. And we could really focus on patient outcomes and get people, because we could tailor the medications to their specific needs. And I think I'm sure something your audience is well aware of. People's health is very unique and very individual. What we bring to the table is just some additional options for people who have those special needs, that need things that are free of toxins, certain fillers, dyes, or medications that just aren't commercially available anymore because a drug manufacturer isn't making them. So it's just a really interesting and fulfilling area of pharmacy. It's a very small niche, and we account for probably about 3% of all prescriptions dispensed. But we always say we fill in the gaps in and around where CVS or Walgreens might have a medication for somebody. Those work for a lot of people, and that's great. And then for those who aren't well served by those options, we can come in and use our clinical expertise to really customize and make something really individualized for a certain patient.
I want to talk about hormone replacement therapy in a bit, but first I wanted to ask you, in general, what kind of doctors go to compounding pharmacies?
It's a great question. We always say there isn't a doctor alive who can't benefit from knowing a good compounding pharmacy. I think the challenge we have is just awareness of what we offer. So for our pharmacy, we do a lot of hormone replacement, a lot of thyroid replacement, specialized thyroid replacement, a lot of dermatology, skincare stuff. We do a lot of men's health, but we can certainly do things for kids. We can do things for elderly patients, wound care. It's almost unlimited. So a lot of our challenge and our responsibility in a way is to just get ourselves out there in front of doctors so that they just know these options are available, and to help them feel comfortable prescribing to us, knowing that the quality is really good and that there's a lot of emphasis and effort put into making sure that the patient is getting like the best quality medication they can get from us.
I always wondered about who's going to compounding pharmacies, because regular pharmaceutical companies, they're constantly sending their reps over to clinics to talk to them, but I've never had a compounding pharmacist come into any of the clinics that I've worked at and just discuss, this is what we do, this is how we can help you. And I really think there's so many things that you guys could provide that they just don't know about yet.
That's absolutely right. And it is interesting because we'll come in and there will be the pharmaceutical reps there, and we'll come up and be like, oh, but we're not like those guys. Like we're more like advisors or something like that. Like we want to, instead of saying, here's the drug I want your patients to, it's more, I want to find out where your challenges are. Who are you having trouble getting well? And then put ourselves out there as a clinical resource for the doctor, which is always surprising to people. I think when they finally understand that's a real genuine offer, that we can actually, you can call us. Pharmacists are so underutilized in the healthcare system. We have all this experience with drug therapy. We understand physiology. We understand how drugs work in the body. And yet we end up getting pushed to the back of some pharmacy, and it's impossible to even talk to somebody because you have to wait on hold for 30 minutes. So doctors just don't utilize us. So I think that's one of the other things about compounding is that it's just a very different experience in terms of the doctor working with us, that we're like, okay, we're going to make ourselves available as like part of your clinical team. I've got a really challenging patient. They're not responding to any of these options that I usually use. They can't swallow a medication. Can we deliver it other ways? Things like that. So I think that's where we come in, which is always for a doctor who's not used to working with a compounder. It's like, what is that? So we have to, but then once that like the light bulb goes off for the doctor, wow, this is incredible, because now pharmacist I can call. It's actually going to pick up the phone in one ring as opposed to waiting 30 minutes. and has all these other options I didn't even know were available. So yeah, we have to get out there and just raise awareness about what we bring to the table and make those connections. And when we do, it's really exciting. And it's exciting for me as a pharmacist because I always wanted to have those clinical partnerships with doctors and utilize what I know and what I can bring to the table. So I think it becomes a really nice bond to establish that relationship with the doctors.
So I wanted to ask you first about dermatology. How can we use compounding pharmacists for dermatology, things like anti-aging, maybe acne, skin issues?
Absolutely. We have so many great options for dermatology. And there's just some very common skin issues that we have really good compounded options for. Acne is one. I have an acne cream that's a retin-A-free option that is basically all natural. It's all using vitamins and other things, but we get very good success with that with our patients. Things for like rosacea. There are commercial options, but when we see a commercially available option, we think, how can I make that even better? So we'll see people getting prescribed something like metronidazole for rosacea. But we say, yeah, but we know niacinamide is also a great topical anti-inflammatory. So why don't we put those together and then put it in a really nice cosmetic cream base so it feels nice to apply. We can even put some scent in it if people want that. So that's where we come at it with some of these formulations. We have options for melasma, things for darkening skin where we can apply that. And just a lot of, and we're really, if you walked into our pharmacy, it doesn't look like a pharmacy. It looks like a lab. And basically, you'll see our technicians all gowned up head to toe. They're wearing head bonnets, masks, and they're really taking the individual ingredients, the drugs, the bases, whatever else we need to make it work, and putting it all together per prescription. So we have a lot of ability to really choose every single thing that's going into that cream to make sure it's absolutely the best quality and what the patient needs. Yeah, there's a lot of interesting topical bases we can use to enhance the effect of some of these skin conditions.
And how about urology? Because I'm wondering about that one too.
Yeah, urology is really more in the men's health field, and we have some options for men. Though it's maybe not your main audience, but certainly for like erectile dysfunction, there are men who don't respond to like the Viagra class of drugs. So we actually have some options that are alternatives for that. And again, they're very good treatments that work really well for men. We just have to make sure doctors know that they're available. So sometimes it's just an awareness thing. So.
And how about pain management too? Because I want to know about that one.
Of course, in the current era, or on the back end of the opiate epidemic, we're really looking for alternatives to opiates. And that was for better or for worse, as people were just given and pain, here's an opiate. And we realized that's just not the best approach. And opiates, interestingly, they treat pain, they mute pain, but they also increase inflammation and create things that make it very hard to get off of, obviously. And so I think it's one of the reasons why it's so hard, because you've created an environment in people where they're very inflamed from the drug, even though it's taking away the pain. So a lot of the things we do are transdermal. We can actually deliver drugs through the skin to the site of pain, which can be really helpful, or other medications that are non-opiate that can have pain relief effects. So it's just looking for alternatives. And really, again, if I can talk to a patient, find out exactly where the pain is, what kind of pain is it? Is it neuropathic? Is it pain that's shooting down your leg or down your arm? Or is it just like, I bumped myself and I've got a big bruise and it's really injured? We can choose the right medications and then deliver it through the skin or deliver it as a nasal spray, things like that, to make sure that it's going in the way it needs to go, so that they'll get that ideally the same level of pain relief, but with a lower side effect profile, obviously avoiding opiates, things like that.
What are an example of some ingredients you might include into, let's say, a transdermal pain cream that maybe don't harm the liver?
Yeah, and even things like ibuprofen. People are popping ibuprofen like it's candy 4 or 5 times a day, and a lot of the issues with ibuprofen in the liver and the kidneys and the gut are from the oral administration of the drug. So if you're taking it for tennis elbow or something like that, delivering that same drug through the skin to the elbow would eliminate exposure to the GI tract, which can increase risk of ulcers. There's less systemic absorption. We don't ever say it's zero because we don't totally know, and it's dependent on the patient, but we certainly know that there's going to be less in the bloodstream. Concentrate that drug at the site of application. It is interesting. If you have, tennis elbow, for an example, you're going to take an oral drug. It's going to go into your system. It's going to circulate around your entire body, and then eventually find the spot it needs to go to that's also going everywhere else. So that would be a very easy example. And then there's more specialized things. Things like neuropathic pain, which is more like nerve-generated pain. And that can be very difficult to treat. People are taking medications like gabapentin and amitriptyline that can be very sedating and cause a lot of other side effects. So again, we can actually deliver those through the skin to the site of the nerve damage and ideally quiet the nerves down without having to have all those systemic side effects.
What about compounded thyroid medication? How would someone who's on thyroid medication know they're a good candidate for that?
That's a great question. And it's something we do a lot of thyroid at our pharmacy. One thing historically, I'll just say, when I was trained in thyroid treatment, when I was in pharmacy school, everyone was supposed to get Synthroid. And everyone knows Synthroid. It's the most standard thyroid replacement. Hypothyroidism is a very common condition, especially for women as they age. But what we found in practice when we started really diving into people's thyroid status is that Synthroid doesn't always address the real activated thyroid issue that patients have. And what I mean by that is that when you take Synthroid, you're basically taking a drug that needs to get converted into the active drug. And it has a very long half-life and it floats around the body. And then the body is expected to utilize that free-floating Synthroid that's in your system and convert it into the active thyroid hormone. And what we have found in our practice is that for some patients and for most of the patients we see, that conversion doesn't happen very efficiently. And I think there's a lot of different reasons why, but one of the main reasons is that patients are chronically stressed. And because they're stressed, and whether it's emotional stress, chronic illness, difficulty sleeping, all that kind of stuff, over years and years, it takes a toll on other systems in the body that diminish the body's ability to actually activate the thyroid. So what we actually give people oftentimes is a combination of the Synthroid piece plus the activated piece, so that they actually have thyroid hormone that's actually going to have its effect right away and rebalance that combination. And it's amazing because a lot of these patients will go to doctors and their labs look okay, although oftentimes the labs are pretty rudimentary. Maybe you'll look at one lab value when you should really be looking at a host of lab values. And they say, I'm cold, my hands are always cold, my hair is falling out, I'm sluggish, I'm constipated. A lot of classic hypothyroid symptoms. The doctor will give them Synthroid, they'll look at this one lab, hey, you look fine, you're good. And we come in and say, okay, let's look a little more broadly. Let's look at more labs, look at your free active hormones and things like that. Let's also look at antibodies to see if you're undiagnosed Hashimoto's disease, which is a very big deal for a lot of patients because that creates a lot of issues with the thyroid. When we look at that, we say, okay, let's say you're not efficiently converting to the active thyroid. Let's just give you a little bit of that active thyroid in addition to the Synthroid piece. And these patients come back, oh my gosh, this is the first time I haven't felt sluggish in the morning, or their quality of life just improves almost overnight. It's very dramatic. And I kind of wonder why we're not putting that into our clinical rationale when a patient comes in with all these symptoms, that why we're not saying, okay, can we actually just give them the quality of life they want? And not just say, your lab looks okay, you're fine, let's move on. So I think that's a big piece of what we do, is just trying to really optimize that thyroid to give them that sense that, yeah, now things are working correctly in my body. And it's really important to have your thyroid optimized. It has a big impact.
So let's get into bioidentical hormones. First, what are they and how are they different than synthetic?
Yeah, bioidentical is a buzzword that's been going around for probably about 15, 20 years now. I think it's coming out of fashion a little bit because for some people it sounds like a marketing term or it's not like real science. And I think that's a little bit disingenuous, but what it really means is that we're giving biologically identical hormones to what the human body makes. That's really the bottom line. So you like it or don't like it, it's really just hormone replacement. And the hormone replacement we're giving is the hormones that the body actually makes. So for example, something like progesterone, the body makes progesterone, and if we're going to supplement, we're going to give progesterone, not medroxyprogesterone, norethindrone, all the synthetic derivatives that have progesterone-like activity. So that's really what bioidentical is. And there's a fairly short list of bioidentical hormones that would be appropriate, and it's progesterone, estradiol, which is the key estrogen, estriol, which is another estrogen metabolite, which is actually an important one for skin health, like testosterone. A lot of women actually really benefit from a very low dose of testosterone. There's some other ones that kind of round it out, like DHEA and pregnenolone, but really it's those main four. And so that's our formulary for bioidentical hormone replacement. And the reason why it's important to utilize these hormones versus the synthetic ones that are not what the human body makes is that those synthetic hormones don't act in the body in very predictable ways, and sometimes in really detrimental ways. So, for example, something like medroxyprogesterone, which is a synthetic progestin, it's not identical to progesterone. It's slightly different, and it's designed to have progesterone-like activity. But when it was studied in 16,000 women in a double-blind placebo-controlled trial, we found that the addition of that drug increased the risk of breast cancer, Alzheimer's disease, and all sorts of other negative outcomes. And the only difference was this chemical structure of this synthetic progestin was slightly different. And so it had different effects on the cells. It got metabolized differently. So there's the research around the bioidenticals, the human hormones, whatever you want to call them, is totally different in terms of its safety profile, in terms of its risk for things like breast cancer. And we're actually going to gain the benefits and increase the safety with these hormones. So that's really what it is. It's just applying the human hormones at physiologic levels that the body's used to making with the intention to have the benefits of the hormones with the least amount of risk and side effect.
So just in my experience, I found that going to endocrinologists, they have not been very helpful figuring out my hormones. So how can you get compounded hormones? Who do you go to? Should I go to the compounding pharmacy and say, who do you work with?
Yeah, it's a great question because we see that all the time. People go to the endocrinologist, and in fact, we'll have people who have been put on really sophisticated hormone replacement regimens, and then they get a second opinion from an endocrinologist, and they strip them away of all this, and all their symptoms return. And all this stuff. So that's not always the case, but sometimes that can be detrimental. So I liked your idea of actually talking to your compounding pharmacy. We don't prescribe, we just fulfill the medications. But as I explained before, we're in consultation with doctors in a really intimate way. So we have every compounding pharmacy is going to have a list of doctors that they work with closely to do hormone replacement, the ones that they really know what they're doing. And there's a level of sophistication you need with this. You need to know how all these hormones interact with each other. You want to make sure the hormones are balanced. You want to look at the person's age. Is a woman still cycling, or is she postmenopausal and stop not cycling? Have you had hormones before? Do you have a history of depression? Do we have to think about how we deliver the hormones in those patients? So I'm not saying it's like outside the realm of any doctor to learn this stuff, because it's really not. And I've trained hundreds of doctors in hormone replacement, and it's not something that's rocket science. They're smart people, but it's just a matter of learning the level of sophistication and preciseness to make sure each patient is getting the precise and exact regimen they need. So to answer your question, a good place to start would be calling your compounding pharmacy and say, who's your best hormone person? And then giving them a call. A lot of these people don't take insurance. So I would just say you might need to invest a little bit of money into having a good hour-long visit with a doctor. And unfortunately, our mainstream medical system doesn't allow for hour-long visits. And sometimes you need that. And I think that's why some of these doctors who are quite good at this have gotten outside the insurance system, because the insurance system forces doctors to see 6 patients an hour, and you cannot be good at this at that speed. So the beautiful part is in an hour, a doctor can really dive into your health status and really figure out what's best for you and come up with the right kind of treatment approach to see you from where you are now. Maybe hormones are out of balance, you're having a lot of symptoms, brain fog, hot flashes, irregular bleeding, whatever, to where you want to go. Feeling good, symptoms resolved, the safety is there, all that kind of stuff. So it's a bit of an investment up front, but it's very worth making that investment, I think, to do that.
So I have a question from someone who has endometriosis, and I thought you'd be the perfect one to ask for this. So she found a few studies that found that endometrial thickness was statistically greater in about half the women who were studied taking hormone replacement. So does that suggest it might not be the best approach for women with endometriosis, or has it significantly changed since the study was performed in the 90s? So are hormone replacement therapies, have they gotten better since then?
Yeah, endometriosis is a very challenging disease, and I'm sure you've talked about this and your audience may be aware of it. Hormone replacement has a role, but you have to be very cautious in endometriosis patient, because things like the estrogen aspect of hormone replacement therapy can actually proliferate the cells and make the endometriosis worse and the symptoms worse. Progesterone can have a role And we have situations where we've been successful giving people kind of high dose progesterone therapy, because progesterone's effect is to really develop and downplay the growth effects of the estrogen on those endometrial cells. And with endometriosis, those cells have left the uterus and migrated into other parts of the body. So there can be a role with that. This is a very patient-specific issue, and there's definitely more to it than just the hormone replacement for these patients. But I agree with you in the sense that you have to be really cautious how you would apply hormone replacement to somebody with endometriosis. I wouldn't have somebody come in and just get the standard menopausal regimen, because it could have untoward effects on the development of those endometrial cells that are causing the symptoms. So that's one where you really want to find somebody who understands what they're doing. Actually, we work with a local doctor who not only does a really nice job with kind of a holistic approach to endometriosis, but also does support groups, because there's a lot of sense that I suffer alone for people with endometriosis. So knowing that, hey, I'm not alone, and connecting with other women who suffer from that disease. So hormone replacement is part of it, but it is something that you want to be cautious with.
So tell us about how safe hormone replacement therapy is, and how has it changed through the years?
There's a really big misunderstanding about the safety of hormones. I really blame the early 2000s. There was a big hormone trial. It was actually the one I referred to about medroxyprogesterone. And what happened with that trial is they were studying that drug with another estrogen drug called Premarin, which is a horse-derived estrogen therapy. And it was a very large trial, multi-center, all what we consider the gold standard type of clinical trial, double-blind, placebo-controlled, all of that kind of stuff. And in 2002, the study designers stopped the study short before it completed, because the women who were on the treatment arm were doing far worse than the placebo arm. And they didn't feel like it was ethical to continue that trial, because they didn't want more people to be exposed to those adverse effects. And it caused such a stir in the medical world that people were flushing their hormones down the toilet. The media really jumped on this. And what came out of that was this understanding that hormones were dangerous. And to me, it was a misunderstanding, because the conclusion we really should have taken from that trial was that these two hormones taken together are dangerous. And it's interesting to me, because I don't know of any other trial where an adverse outcome came and then we implicated an entire class of medications out of the results of that trial. And maybe it's because it's a women's health issue and there weren't as many women involved in the decision making at that point. Because to me, what was happening was women were told, oh, you have hot flashes, go get a hand fan and just grin and bear it. Oh, you can't sleep? Well, that's tough. That's just menopause. And to me, that's an unacceptable answer for women. And what's more frustrating, and what really got me passionate about this topic, was that when you went in and looked at the data and the research around bioidentical hormones, human hormones, versus these other hormones that were studied in that trial, the safety profile was completely different. The risk of breast cancer with bioidentical hormones has never been correlated. And there's an excellent book, if you're really interested in that, called Estrogen Matters. But the research around cardiovascular disease and strokes and heart attacks was completely different, especially if we delivered the estrogens through the skin and not orally. So it was one of those things where it's like, why aren't we're doctors, we're supposed to understand the research, we're supposed to be the ones who are evidence-based. Why aren't we reading the evidence and really understand what's going on with these hormones, versus just saying, oh, hormones are dangerous, I'm going to be committing malpractice if I give a woman hormones? We need to be able to give women options that are going to help relieve their symptoms, going to help them live healthy lives that are with longevity. And these options were always there. And the safety was always well demonstrated in these other studies that looked at bioidenticals. So that got me really passionate about this. And I think I still am arguing and educating and talking to people about this misperception that hormones cause breast cancer, that hormones are dangerous, that it's really irresponsible, it's not natural. To me, having hormone deficiency is not natural. The body does not function well when hormones are deficient. I think for me, the conversation I want to have is, are you harming people by not giving them hormones? Because we know that women are living longer than ever into their 80s and 90s. This is a generation now at that age that's expecting longevity, expecting a quality of life into those years. And hormone replacement has a key role in preserving bone and preserving the brain, preserving muscle. So when we look at what's going on in terms of the need and the research, there's absolutely an appropriate case to be made for the right kind of hormone replacement for an individual. So there we go. I'm putting it out there to your audience now because I really want to debunk the myth that hormones are dangerous. When they're applied correctly, when they're the right hormones applied correctly, they can be done very safely. And we have lots of ways to monitor and make sure that they continue to be safe, because safety is at the cornerstone of what we want to put into our mindset when we apply a therapy. And I feel very confident giving people bioidentical hormones.
When it comes to estrogen dominance symptoms like migraines, for example, I've heard some doctors suggest taking more estrogen during the dips in your cycle. Do you think this method would work? Or do you think adding more estrogen would just be worse overall for these people?
Yeah, migraines are interesting, and especially if it's like menstrual migraines. I think any symptom that comes in a cyclic way with the menstrual cycle has some sort of hormonal component to it. It has to, because the hormones are cycling through that cycle. I think migraines are no exception. I will say the best success I've had with hormone replacement for migraines is giving women progesterone. Because I think, and you talked about estrogen dominance, which is really what happens when you have more estrogen than your progesterone. The estrogen effect isn't well balanced out by the progesterone. And if you look at the menstrual cycle in general, progesterone really comes in the second half of the cycle. And its job is to contain and control the proliferation of the cells, the proliferative effects of the estrogen. So if we have an estrogen dominant situation, we have lots of energy going into proliferation, inflammation, growth, but not enough of the control effect that the progesterone brings. So I've had very good success applying progesterone in those patients. There can be cases where giving some estrogen as well can help balance out the peaks and troughs. We see this with hot flashes too. Like a lot of times those symptoms can not be so much about the absolute level of the hormone, but the fluctuating effects of the hormone. So sometimes if we give an appropriate amount of estrogen, that kind of mutes the trough, if for lack of a better explanation. The peaks don't go down as low, so that difference isn't as great. But I would never do that in the absence of adequate progesterone, because I feel like when we see estrogen dominance, we either need to bring the estrogen down, and if we're not supplementing, then there's not a lot of ways to do that. There are some, but they're not very dramatic. But bringing the progesterone up is something we can do. And that addresses that, because now we have adequate progesterone to that level of estrogen. So that would be where I would start. And then obviously, again, patient individualization. When does it happen? What part of the cycle? Because if it's happening late cycle, that is definitely a progesterone. That's when progesterone comes in. And we see this even in women in their 20s and 30s, lots of late cycle symptoms that are well controlled by just late cycle progesterone. You take it from day 14 through 28, and get that progesterone level up a little bit more, and it balances out with the estrogen that they've produced. So hopefully that answers your question.
What are your thoughts on those wild yam creams?
Not a huge fan of those, mainly because I like bioidenticals, and I'm adhering to that principle of hormone replacement, which is human hormones given at physiological levels, and really looking at the symphony of hormones, they call it, looking at how all the hormones relate and react, have activity with each other so that they're well balanced amongst themselves. It's really hard to do good hormone replacement if you look at just one hormone. You've got to be a little bit more broad and look at how they interact. So wild yams, they're not bioidentical. They're not human hormones. What the estrogens that are in yams are different than what the human body makes. So if I'm going to really help somebody balance their hormones, I want to give them human hormones, the bioidentical hormones, because those are going to be the ones that have very specific effects in the cells. The body's used to utilizing them, very specific metabolism, and there's a lot of research to support their safety. You can't buy these over the counter, so that's a downside. You have to get a prescription for them, but those are the ones that are really going to have the effects that we want for our patients.
How can bioidentical hormones help women with high androgens?
Yeah, and something like a PCOS presentation or high androgens. Yeah, that's tricky too. Progesterone can have a role in some of that stuff. PCOS is its own separate issue that may or may not have an appropriate hormone replacement component to it. So I think that's not usually where we start with those patients. A lot of it has more to do with nutrition and other aspects like that. But we can do things like give supplements to help people metabolize hormones better, get some of those hormones out of your system. It's interesting, the human body is very good at retaining hormones. Like estrogens, they recirculate through the body. They don't really leave the body very efficiently. So sometimes we have to encourage metabolism of hormones. There are certain supplements that we can give, like DIM and calcium D-glucarate, that kind of help encourage the detoxification. But something like PCOS and those areas, hormone replacement would be down the road if we needed to bring that to bear. Focusing on gut health, nutrition, maybe some of those supplements I mentioned probably would be where we would start and see if we need to do some balancing down the road.
When you do compounding, can you take maybe like some supplements that are usually over the counter and mix them with pharmaceuticals and natural hormones?
Yeah, for sure. And again, it's the approach where when women, certainly during menopause, the hormone levels are really dropping over the course of 5 to 10 years, depending on the woman. What we're really trying to do is bring back a minimum baseline of hormone function in the woman so that we're maintaining the bones, we're maintaining the brain, we're maintaining the muscle, and treating any symptoms a woman might be having through that period. We're giving a pharmaceutical or a prescription, I should say, but it's not really a pharmaceutical. It's really more just shoring up that endocrine system with the hormones that the body's been producing already. It doesn't really have any interactions with supplements or things like that because we're really just getting people to a place they've been before, if that makes any sense, in their hormone profile. So you can definitely take other supplements like vitamin D or fish oils or things like that. They're not going to have a negative impact. And I think it's actually very helpful for women to really think about taking the right supplements just for general health, because your baseline health status has a huge impact on your utilization of these hormones and whether they even work at all. Things like stress management and nutrition, but also gut function, taking a probiotic can be really helpful in some patients. So there really isn't, it's actually, in some ways, it's actually good to do that. It's actually good to have a very holistic approach that you're looking at all the kind of supplements you need to get your general health status where it needs to be. The hormones are going to actually work better.
What is the best way to take hormones? Should you cycle them? And tell us about the different methods of application.
It's a good question too. It really depends on the patient. And there's different approaches. And as a pharmacist, we work with a lot of doctors and everyone has their own way of doing it. And it's not necessarily right or wrong. I think that's true in medicine in general. There's lots of ways. And what's right is what's right for the patient. And that's why having that relationship with the patient for us is so important, because they can tell us, are we on the right track? And so it's very important to have that kind of feedback from the patient. So for me, my approach is if a woman is cycling, I like to cycle the hormones because we want to go with the natural production. And in those cases, we're augmenting the balance of the hormones, but we're not going to be taking over. If you give a woman birth control pills and they're cycling, you basically just lay waste their cycles. It takes over the whole system and it replaces it with the medications that are in those birth control pills. We don't want to do that. We want to allow the body to make the hormones as it does and then augment them in the right way so that they're well balanced. So if a woman's cycling, we like to cycle. If a woman's postmenopausal and not cycling anymore, there's really no need to cycle. Most women don't want to have a period anymore. So we can give them low dose of a continuous therapy, and that works great. And it's easy to take. You don't have to remember what day of the month it is and things like that. And then in the middle, we have our perimenopausal women who have irregular cycles, and that gets a little tricky. So we do the best we can in those situations and probably do a combination of cycling and continuous based on their profile. In terms of delivering the hormones, progesterone and estrogen have different ways of entering the body if they're taken orally. Progesterone can be a very nice oral medication. And actually, it's probably our go-to because it really helps with sleep. It's highly metabolized. All these hormones are highly metabolized in the liver. So anything you take orally goes through the liver before it enters the bloodstream. And a lot of these medications are highly metabolized, and all these hormones are. So progesterone is actually highly metabolized, but one of the main metabolites that gets produced in that really has a high GABA effect in the brain, and it really helps with sleep. And that tends to be one of the main complaints women come into a clinic about, not just the hot flashes and brain fog. And so it's a really nice way to balance the hormones and give them a natural sedative that's not going to disrupt the sleep cycles. There are some cases where oral progesterone may not be appropriate. For example, in a patient with major depressive disorder, sometimes that metabolite can actually trigger some depressive episodes. So we would have to find alternatives. And this is where delivering it through the skin is an alternative. Estrogens, on the other hand, don't do good things when they're given orally. They mobilize a lot of clotting factors in the liver, so they increase the risk of blood clots. They increase what we call sex hormone binding globulin. And what that is a substance that the liver creates to carry the hormones through the blood. But when we increase the levels of that, it also binds up all the other hormones like testosterone. And so it lowers the activity of the testosterone. So in general, we don't like to give oral estrogen. So we would give that transdermally. However, there's one caveat to that, is that giving hormones through the skin can sometimes give us challenges because the skin is designed to be a barrier. Stuff's not supposed to go through the skin. Now, hormones are good candidates for transdermal drug delivery because they have the right qualities to actually get through the skin just in and of themselves. We don't have to do a lot of things to drive the hormones through the skin. But we find some variability from patient to patient when we have them apply it to just the general skin. So the preferred way is transvaginal administration, because if we can give the hormones vaginally, we don't get that difference between patients in terms of how well they absorb the hormones. So that's really what I encourage doctors to talk to their patients about. And if some patients are just like, I'm just not comfortable with that, okay, we can do the transdermal. We just have to monitor it a little more closely. We also have to make sure that they're not going to share that hormone with a partner, a child, or a pet, because it's going to be out there on their skin, and there's a risk that they can transfer that hormone to somebody else. So there's just more counseling involved with that as well. So hopefully that answers your question. There's, again, patient-specific, but oral progesterone is a good go-to. Vaginal hormone estrogens are a good go-to. Same with testosterone as well.
How long does the estrogen remain on the skin?
We counsel to be extra cautious for the first 2 hours. Most of the research shows that the risk of transference can exist up to 24 hours. Obviously, it's a diminishing curve, and that's a very conservative estimate. So with that being said, we say it's prolonged skin-to-skin exposure. And in the case studies we've seen where we've actually seen real consequences from transferring that hormone to somebody else is when you're either sleeping next to your partner with your arm or part of your body that's applied the hormone on their skin for a prolonged period of time at night, whether you're holding a pet in your arm where you've applied the hormone or holding a child in your arm where you've applied the hormone. So if somebody brushed by your skin or something like that after a couple hours, that's not really what we're concerned about. We're concerned about that prolonged skin-to-skin exposure, and it really shouldn't happen anytime. For the first 2 hours, that's when the risk is highest. And we also recommend not showering in those first 2 hours. Ideally, you would shower first, then your skin's nice and hydrated, all the dead skin's been sloughed off, and you apply your hormone there, and then cover it with clothing, and then just be careful with having prolonged exposure of that area of application to somebody else's skin.
So I'm going to ask the question because I'm sure people are wondering, how long do you have to wait if you do vaginally before you can have sex?
We really recommend, if you're planning to have sex, just skip the dose. Because if you've been on the hormones for a long time, missing one dose isn't really going to diminish your hormone levels. Because now I would say it goes into the pool, and the pool is well filled with hormones, and one day isn't going to drain out the pool. So just skip the hormone for that day or use it after sex. So that's really our recommendation. Yeah, so there is a risk of transference with that as well. That's our counseling tip for that.
Okay, fair enough. All right. How has hormone replacement evolved over the years? And where do you think it's going?
Yeah. The research I'm referring to that showed the safety and the efficacy of bioidentical hormones, and obviously thousands and thousands of patients having done this, hasn't really changed that much in the 20 years I've been involved in this industry. It's interesting. And a lot of the approaches we started utilizing a decade ago still are really valid today. So that's interesting. What's changed is people's awareness and understanding of the safety of the hormones. And I think a lot of women's demand to have this therapy. It's not acceptable to say, oh, you have hot flashes and you can't sleep. Here's some Ambien and a fan. I want something that's going to really address this issue and be safe. And when the research is there. So what I've seen in my career is a lot of resistance to any hormone replacement, to a begrudging acceptance because the patient's demanding it, to a mild embrace, I should say. A lot of OBGYNs are now giving Viavel patches and some commercially available oral progesterone, which is great. This is what we want people to feel comfortable with and feel safe, that this is a safe option. what I'm hoping that the future is that we'll really start seeing the long-term impact and importance of shoring up women's hormones as they age, because we are living longer than ever before. 100 years ago, the life expectancy was in the 50s, and 100 years before that, it was in the 30s. Now, it's very reasonable for a woman to expect to live into her 90s. Very reasonable. My kids keep telling me, and they're like pre-teens and teens, I'm going to live to be 100. And I think, yeah, you probably will. I mean, we've just extended life to that point where our knowledge of nutrition and how to create longevity is just so much better. Our treatment of infectious diseases, the pandemic notwithstanding, is just orders of magnitude better today. So women are going to be living a significant portion of their lives postmenopausally, from 55 to 90s. And what concerns me is that if we don't really get aware of the negative consequences of hormone deprivation and low estrogen levels on the bone, on brain protection, on muscle protection, we're going to have an epidemic of Alzheimer's disease, osteoporosis, sarcopenia, things like that. So that's where I really hope we're going with this. We know now, and I think there's an embrace that we can give these hormones during perimenopause to treat the acute symptoms of menopause, like hot flashes, brain fog, night sweats, all that stuff. And I think we've come to an acceptance that that's okay. But what I really hope we can talk about is the long-term benefits and how we can give women quality of life through strong brain, strong bones, all the way till end of life. And we can do that with hormones. And I'm hoping that conversation continues to happen and we can really help women prevent those problems, not wait till they happen and then start to find some miracle drug that's really not going to solve it because it's too late.
Why, in this case, is Big Pharma lobbying against bioidentical hormone replacement therapy? My guess, patents, money, but what do you think?
Patents, money? Yeah, I think it's really misguided. Big Pharma, they make a lot of money, so I don't know why they need more. I think they see us as competition, but they really shouldn't, because we don't see ourselves as competing with them. If somebody's doing well on a pharma product, they're thriving, they're feeling great, they're on a safe regimen, I'm not going to recommend they switch to a compound ever, because I want what works for the patient. So I really wish that pharma would understand that we're only coming in for those patients that their products aren't working for them anyway. They're not going to be on a pharmaceutical product. So it's misguided. I think it's profit driven. That's just my opinion. I also think that we live in a regulatory apparatus that has really pushed like this kind of protocol-based paint by numbers medicine. And as I've described what we do, we're not paint by numbers. This is very individualized. This is very boutique, and it doesn't fit a standard protocol because people's health don't always fit a standard protocol. In fact, most clinical trials only look at a very small segment of patients for this therapy. And what we should be doing is taking that data and utilizing it to better understand how we can treat each individual, knowing that they may or may not respond the same way. We really want to embrace this idea that we need options for patients that just don't fit the mold, and health is complex. So we need sophisticated solutions for a lot of patients.
How can we help ensure that these therapies are protected from overregulation?
One thing you can do is go to the website compounding.com, where we're trying to gain testimonials that we're putting together in case the FDA or some regulatory body comes and says, hey, you can't do this. We're very concerned that may be happening. The FDA has commissioned some studies that were very slanted against compounding and didn't really take into account this patient relationship that we have and the wonderful and amazing patient outcomes that we get and these testimonials. So that's a place you can go in and actually write a testimonial that will be compiled and presented to the FDA. And you can always look at our website at koshlandpharm.com to look at some information we have about just bioidenticals in general and compounding and what we do. We have actually a 6-minute virtual tour of our lab if you're interested in just like how some of these compounds get made and some of the quality assurance around that. Yeah, there's right to your congressperson. We're not in a situation now where things are immediately threatened, but we don't want to wait until things are really threatened to start acting. We want to be proactive and say, now, please don't touch this therapy. This has changed my life. This is something we need to protect and preserve, and get that information out there right away.
So How can everybody work with you and find you?
So we're in California, so opposite end of the country from you in Florida. And we work with patients all throughout California. So you go to our website, KoshlandFarm.com, if you're in our state. If you're looking for a compounder in your area, let us know. We can help refer you to somebody. We have a network of pharmacies all over the country and some amazing practitioners all over the country who are doing amazing work for their patients. So no matter where you live in the United States, there's somebody that can help you. And we want to help connect you with that right pharmacy that can get you started on that journey. You can start with us so we can help put you in the right direction. If you're in California, we can work with you directly.
Alrighty. I'm going to put all of that information in the show notes, and hopefully we can make sure that compounding pharmacy never goes away.
Yay. Thank you so much.
All right. Thank you for your time.
Take care.